Welcome to the another part of the presentation on the case selection and treatment planning for partially edentulous cases. So you need to understand for the partially edentulous cases, you still can go for single crown, implant dent, single crown or implanted in bridge or partial overdenture with the implant supported removable option. So it can be either a fixed option or a removable option, and accordingly you need to change whenever you are thinking of joining the implant crown with the tooth abutment for the bridge. You need to understand the compressibility of a periodontal ligament of a tooth abutment against no compressibility of an implant in the bone. So that discrepancy may cause some of the stresses around the implant, and that's one of the school of the thought. But evidence of uh, n number of clinical evidence nowadays are indicating to us. You can check on many systematic reviews on the success or rate of the implant or a bridge prosthesis which is joined with the implant and the tooth supported restorations have a more or less equal success rate. So as long as it is short span restorations, I think the evidence is still uh, uh, both ways, whether few clinicians will be against the thought that you should not be joining. However, now recent more and more evidences are coming up to indicate that you can actually join the tooth with the implant to support the bridge prosthesis. Okay, so prosthodontic driven to implant concept is something which is you need to understand as well. Like you have to plan the restoration first, and then you place the implant, and then you plan the implant position. So, if your restoration is in an ideal position, there is highly chance that your implant will be having a favorable stresses. In terms of that concept, if at all, if you have planned the crown first and then you are planning implant, and then if you have few more bone availability issues or few of the bone dimension issues, you always can go for bone grafting procedures and augmentation procedures accordingly. So, or however, you can also select the alternative plan or uh, alternative options to join the the prosthetically planned crown, yeah, with this smart selection of our diameter and length of the implant and position of the implant to anchor the restorations. So planned preoperative or a pre-operative and a soft and hard tissue augmentation and the regenerative procedures for implant site to develop, so that your crown restoration will be still in the ideal position, and do whatever to place that implant in that particular supporting ideally placed restoration by augmenting and and uh, and increasing the volume of the bone in that particular direction. And you look at the survival rate of implant supported single crown versus implant supported fixed bridge versus implant and a tooth supported fixed bridge. So in 2015, there was one systematic review which was really indicating that in joining the implant and tooth supported fixed bridge also having little bit of less success rate, however survival rate, however it is still 91% over, and that can be an option. It's not like a disastrous option, we would say. So as and when a case is required, you can actually opt for this option. It's not completely cannot be a contraindicated. It cannot be a contraindicated completely. Okay, so against this implant supported single crown or implant supported fixed bridge of a 94 to 96% of success survival rate. It's just not that less survival rate for the implant to tooth supported fixed bridge. Treatment planning procedures, information of the gathering, diagnosis and identification of appropriate treatment options, imparting the information, further information gathering with a detailed treatment plan, status of the implant paid, and then presence of vital anatomical structures, and treatment planning with acquiring the patient's consent. So all these aspects are also important. So information gathering, usually it is a typical case history where you need to understand and take the history of a concerned patient's expectations. You need to understand the patient's expectations
Dental and social history, medical history, clinical examination, extraoral or intraoral diagnostic imaging, and special investigations, usually for the CBCT for implant restorations, and then the photographic and radiographic records to maintain. History of a concern, cause for the tooth loss, what is the timing of a tooth loss. So if you have a time since extraction is a 0 time or 4 to 8 weeks or 12 to 16 weeks or 6 months or over, accordingly you have a classification based on whether you are planning the implant placement, immediate placement or early placement or delayed placement or a late placement. Accordingly, you have different clinical properties of the bone you can expect in those zone. More or less in a 0 immediate placement time, you have a no post extraction healing and bone or no soft tissue or volume available within 4 to 8 weeks of timing, which is also called as early implant placement, which is significant soft tissue healing is there, but there is a little bone, a new bone formation there. 12 to 6 weeks time is significant soft tissue healing is occurred, and significant bone healing also is occurred. 6 months or over is a late placement, which is a fully healed site. So this is a basically classification given by uh, earlier few of the international team for implantology people. So that can be followed earlier. Patient's expectations, whether it's a functional expectations or aesthetic expectations or time constraints or financial constraints, all these aspects you need to understand when you go for the dental or social history. Look for the oral hygiene habits, bruxism important because that is one thing which even if you after implant osseointegration, bruxism habit is the one which is more detrimental to the implant restoration because implant don't like lateral forces. Yeah, and that's how. So, what is the type of diet? Whether it's a non-vegetarian, vegetarian, hard food, soft food. Smoking is also another triggering factor. It increases the implant risk of implant failure by 2 to 3 folds. Alcohol consumption and history of periodontitis. Well, so medical history, you can see radiation therapy, medication, psychiatric disorders, or immunosuppression therapy, recent myocardia infarction, or cerebrovascular accidents, or valvular prosthesis. All these medical history are important. There are few areas where you should not go for implant treatment at all, are like absolute contraindications, and few are relative contraindications for implant placement. In extraoral examination, you can look for the facial profile, lip support, smile analysis, speech and lymph nodes. In intraoral examination, you can look for occlusal relationship, parafunctional habits like earlier mentioned about this bruxism or cleansing, tongue thrust habit, biotop of soft tissue, then periodontal examination, dental examination, implant site examination, with the ridge dimensions, ridge width, interdental spaces, interarch spaces, tilting of the abutment teeth and over eruption of the opposing teeth. So all these are so that you can provide the enough restoration space for the restoration. So diagnostic imaging, as we know about that the CBCT is a very important tool to have a important diagnostic imaging technique where you can plan the implants, and nowadays with the help of sophisticated softwares you can do everything planning virtually to generate the computer planned information, and they can transfer that into a physical form by 3D printing the files which you have generated in the software with the help of implant planning softwares. So limitations of dent, yeah. So few imaging techniques are not really looks like a very fancy, however, are not really important to or are not really very accurate for implant treatment. So OPG is one of the uh, limited used or limited scope imaging technique for implant dentistry because it gives a two-dimensional thing. There are few magnification distortion issues and some of the superimposition of spinal column in the anterior zone. So in that case, if you cannot really make a CBCT imaging, you can always go for a PA radiograph to evaluate the bone well. Yeah, so uh, that's exactly what is the issue with the OPG. Yeah, the another technique, if you don't have a CBCT available, you can do the bone sounding measurements by at a different level of tissue thickness. You can pierce by you may give a local anesthesia and you pierce the probe to evaluate the actual bone width and that bone width you can actually sorry, the soft tissue width, and then soft tissue width you can actually transfer it onto the cast by measurements of those particular areas with the help of that specific file, and then that information of an amount of soft tissue thickness can be actually transferred to your hard cast, and then you can evaluate or estimate the bone width to plan the implant placement and select the implant with implant diameter and the length accordingly. So that is called as a bone sounding procedure. It can be actually bone mapping procedure also, you can tell, and it can be actually clubbed with the help of simple periapical intraoral periapical radiograph. And if you have a periapical radiograph and bone sounding procedures, you can perform well. That can up to certain extent will be replacing the need of CBCT, or so that's basically a conventional procedure to estimate the bone dimension in that area. Special investigation, as we have already mentioned, few of the dental pathology, pulp tests or biopsies or medical conditions for blood tests and refer for the medical practitioners are important as well. That's all for this presentation. Thank you very much for your patience listening.